Right, so our next speaker is Ashlea Hooman. She is a trainee ACP, trainee midwifery ACP, and she's going to talk about the role of the trainee ACP in triage. Thank you, Ashlea.
Thank you. I will just share my screen. Okay. So hopefully you can all see that. So yes, my name's Ashlea. I've very recently qualified as an ACP and started my qualified role in the last week or so, actually. But I'm going to talk about my journey right from the beginning, getting through the training and how the kind of difficulties that I faced and how we've overcome it within my trust. So a little bit about me. So I qualified in 2014 and just worked initially as a rotational midwife, but always with an interest in delivery suite where I spent most of my time. And then a few years later, I started working as a bereavement support midwife, and I did that 50% of the time, and then I worked clinically 50% of the time. And that was a really good kind of role to understand the outer workings of the maternity unit rather than just the shop floor, so having a bit more insight into the governance processes and things like that. And then in 2020 I started my master's in advanced clinical practice, and I'll go through the studying side of it a little bit more. And I then had a year off, had a baby, and we then went into after COVID, and then when I came back, I started working as a delivery suite coordinator while studying. And then in September last year, I started a role as a trainee ACP for the final year of my studies, which I've just finished. So how this kind of happened for me. So we had, I think, a trust-wide email advertising the course, the Masters in Advanced Clinical Practice, funded by Health Education England, and there was just a, if you want to give it a go kind of attitude. No one really had any idea what it would look like, and it was a multi-professional course. So I applied for that without really any plan for where it was going to go, how it was going to be implemented, or really, honestly, any true understanding of what that course would lead to and what it would mean for me as a midwife and for maternity services. Our senior leaders at that time I don't think also have any real grasp on where that would go to, but they were happy to support one person to do it. So I think a few of us applied, and they were happy to fund one person, which wasn't me, but we will come back to that. So when we applied for that, so when we started that, there was no plan in maternity, and it was actually made very clear that although this is we'll give you the time to do this or whatever, there's definitely no job at the end of this, and you may just do it and then nothing will change. So that's kind of how we went into it. And then starting the course very quickly, it was made, I think one of the first modules we did was exploring and challenging advanced clinical practice. And I think that's when me as an individual and talking with kind of matrons and senior leaders started to think about where we could see an ACP in our maternity service. We are a unit, we have about 5,500 deliveries a year. So we've got a birth stand alongside birth centre and a delivery suite, and then the wards. So we were looking at where it was needed. And one of the ideas that I think was put out there was for enhanced care, but that it was quite quickly ruled out in that we don't probably have the need for an ACP in enhanced care currently, because we don't have that many patients that unwell. We looked at delivery suite, but quite quickly settled on triage as the area that has the most need for an ACP, and the area that in the inpatient setting is often not neglected, but not a priority in the day-to-day running for patients and reviews and timings and things like that. So prior to starting my studies, the current practice in maternity triage is that we would have 2 midwives, a band 7 and a band 6 in triage. We have introduced BSOTs during my training, but we do BSOTs. And for reviews, we had no timings for medical reviews. We just had the timing for the BSOTs, which I think when we initially started using BSOTs, the thought was that the timings were for the medical reviews, where actually they aren't, they're for the midwife reviews. So we then had the on-call team reviewing patients in triage when they had a moment, which often was, well, I'll come to a little order in a little bit, but sometimes we had patients waiting six hours for a simple prescription for a urine infection or something like that. So it was a real area that we could see that needed change. And I think for us, it was working out who is the best professional to fill this gap. So we know that we have junior doctors rotating who are brilliant, but don't have the experience in maternity to confidently make plans. Gaps in the medical rota mean that although there is a gap space on the medical rota for a medic in triage, it was never filled. So we looked at how ACPs work and in other areas of the hospital, and whether that was an area that a midwife ACP could work and fill that gap. And looking more into it, it became a really exciting opportunity for progression for midwives who wanted to remain clinical, but were either at band 7 or wanted to progress to the next kind of stage, but didn't want to go into leadership and management. So this all kind of happened within the first year of my training, looking at where the area will be, where we want the ACP to work. But it was also made very, very clear that there was still potentially no job at the end of the training, and we will just see how we go. So with my studying, as I said, I started in February 2020, and after I think 7 or 8 of us applied for the position, they said that they would only support one of us. So they picked names out of a hat, and my name didn't come out. So I approached the head of midwifery and said, can I do this in my own time? Can I have the protected time off? So I did the first year with no hours, no study leave, and no clinical time to complete my health assessment module. So at the university, we had to do 72 clinical hours for our health assessment module. So that was all done within my own time. So I started in February 2020, just as we kind of went into COVID. I was also then had a baby, went into maternity leave. So when I came back from my first year, I finished that year in my own time. And then for my second year, I think for the last term of my second year, the midwife that had been given study leave, I think, had dropped out actually. So I think she'd had some time off and then decided to take a step out due to kind of personal reasons. So I was then able to get the university time, to attend university, but no clinical time for the then prescribing module. So it was an improvement definitely from my first year, but still I was doing all of the clinical hours and everything in my own time. And then for my final year, so during my second year, there was a lot of conversations about how it was becoming more known. I think people were talking about it more, and I think kind of regionally there were more awareness of ACPs in maternity. So it became more attractive then, I think, for us to consider actually that this could be a job, and it could make a difference to our trust. So during my second year, it was agreed that for my final year, starting in September last year, I would work as a trainee, so fully supernumerary as a trainee ACP, with time to attend university, which I think was only about 4 days in the end because it was the dissertation module, but time to kind of work as a trainee alongside the obstetric team and really embed how this is going to work when qualified. So this final year has been invaluable. I've been completely supernumerary for the whole time, working alongside the on-call team, and as well as doing the work alongside the on-call team, I've managed my own rota and had opportunities to work in different areas. So from doing this study day last year, I remember Sam saying all of these things she'd done and thought, oh, that's a really good idea. So that's what I've made sure I've done this year while I've been supernumerary. So I've spent time with women's health physios, the obstetric anaesthetist, medical same-day emergency care, and doing different antenatal clinics, colposcopy, A&E, things like that. And all of those sessions have been really invaluable in their own way, because I know for myself, making plans for obstetric patients from an obstetric point of view, I've definitely built confidence in it. I feel quite comfortable with it. But seeing patients presenting with chest pain and shortness of breath and things like that, things that we before would have just done a quick assessment and then got the doctors to review, his has definitely been quite a steep learning curve. And I know that this was touched on in the previous presentation about knowing the limits of our remit as ACPs. And I think during this supernumerary year, I started very much sticking very closely to the registrar when they were in triage, doing all the reviews alongside them. And that's very much evolved to me now doing the reviews, and at the end of the day, kind of talking about the plans that I've made and anything that needs to be changed. But with the more medical presentations where I haven't felt comfortable, I've called our SHOs or whoever is the most appropriate person and reviewed the patient with that medic to help build my own kind of competence. So it's worked really well. So clinical supervision, when I started the course in 2020, they said to us all, you'll need a clinical supervisor. So I just went and spoke to one of our consultants who was very happy to do it, but really didn't have any awareness of the role, of what the role will become. And I think that that's been the theme throughout the whole of my training. So they've been very supportive when I've asked for help, very supportive when I've wanted to do different things and giving ideas, but there's not really been any any kind of suggestions out from them without prompting. It's been very much, if I need something, then they're there, but otherwise I'm kind of left to my own devices. So when I started the trainee role, I was very conscious of what my kind of clinical supervision and escalation were. But it was just kind of made that it would just be the on-call team on the day, and then I could seek out my named consultant if I needed them. So whereas I know Sam's had the regular catch-ups, I think that's something that I will definitely look at and go, and moving forward, make sure that I do, because I think sometimes you just are doing your job every day and you don't necessarily take note of what's been happening and where you're progressing. So I think that's definitely something that will help going forward. And then I've also had a number of named senior registrars. So I started kind of planning my days around their rota, but that quickly became not very easy to do. So I've then done set days, but with the teams that tend to rotate on those days. So it's worked really well. And at the start of my training period, there was a bit of information sharing to kind of the wider teams and medical and midwifery teams about my role. That being said, having done it for about 9 months and now qualified, there's still people saying, "Oh, what are you doing?" So I think there's still a lot of learning to be done, and I think that's a theme throughout. So one of the biggest barriers, as I just touched on, is the lack of understanding and awareness of the role from everyone. So from support workers, midwives, doctors, all the way through. There's a real lack of awareness of how ACPs work in midwifery. We've not had any ACPs in midwifery before, and although they are in the hospital, I'm sure everyone's the same, that midwifery is very much its own entity, and we don't have much to do with kind of other areas. So it's very, there's real little awareness. And to begin with, I think the understanding of what the remit of the ACP is, and I think that's not just for others, that was for myself as well, because although we have patients in triage who have either an SHO review if they're presenting with pain, bleeding, a more medical perspective, and then we have registrar reviews for more care planning in pregnancy, so reduced movements, PT, growth problems, things like that. So although the registrar level reviews are more what I'm used to, I have still there was no real plan for, these are the patients that you will see, these are the patients that are outside your remit, and it's just been developed as I've gone, but by myself, really. No, not really by anyone saying that this is what is and isn't acceptable. So a lack of clear job plan. So I was saying to Sam on the phone earlier, I've finished my training now, finished my training year, or 9 months, without a job plan or description, and I've now started my ACP role on the 1st of July, again without a job plan or description. So it's definitely a work in progress, and it's definitely a slow work in progress, but we are taking small steps. So, and kind of minimal awareness of the current stage of studies and progression. So when I was going in to do time with pharmacists or GPs, or different, I don't think there's any awareness from the maternity and medical side about what experiences, exams, teaching I've done to kind of reach this stage. Enablers, so the supernumerary status has massively helped. To have this year has been really invaluable. for me and for the MDT, I think, to kind of learn how this will work has been really, really good. And despite the lack of understanding, the enthusiasm from all members of the MDT has been really, really positive. So everyone's been really positive about the introduction of the ACP, even not quite understanding it. We've had really positive feedback from patients in triage, and the ability to support both midwives and medical staff in triage has been really good. So as the new SHOs rotate, being able to support them has been really good, and support the midwives in triage. So this is a very small audit that I did at the end of last year, just looking at how our triage runs when there is a trainee ACP there and when there isn't. So I did it over 2 months. I think it was October and November, or November and December. And we had 1,859 patients attend in a 24-hour period. And, over the 2-month period. So with an average of 31 patients attending a day, and 87% of these patients required a review, and you can see their allocation there with using the BSOTs. So during that same period, out of the 90 available sessions for medics, so that's Monday to Friday, morning and afternoon, only 20 were filled. So 78% of the time there was no allocated medic to triage. And I looked a little bit at where their allocation covers. So the middle grade allocation is from 8 AM till 1 PM and 1 PM till 5 PM. And interestingly, the acuity is highest in triage from 12 till 7:30. So it really wasn't working. When they were there at 8 o'clock in the morning, there weren't patients. And so waiting time. So when there was no medical cover in triage, so when they were just using the on-call team, we had an average waiting time for patients of 3 hours and 50 minutes, which could be as simple as a prescription or a care plan. And some patients waited up to 8 hours for an on-call doctor. And when I first started, so in November, when I was there, the average waiting time was reduced to 50 minutes and the longest wait was 90 minutes. So really drastically improved for the patients and for the staff as well, because I know that for the staff, the worst thing is having patients constantly, rightfully, asking when they're going to be seen because they've been waiting for such a long time in an uncomfortable waiting room. So one of the things we've recently introduced only in the last couple of months is targets for medical reviews. So within the BSOTS guidelines, all patients should be seen within 15 minutes and allocated a risk factor for how long they've got to complete their assessment by the second midwife. But there was never any suggested or set in stone times for medical reviews. And I think very much in triage, because we weren't missing anything, there were no red flags because the midwives were seeing the patients in a timely manner. There was no red flag that a patient had been sat there for 6 hours in triage waiting for something. Then there was no escalation that actually this isn't working and we need to make a change. So I'm really hopeful that the introduction of these medical review timings will mean that either when I'm not there or when I am there and it's busy, and we're not meeting these times. So red is obviously immediate, that's the emergency. Orange, 15 minutes, yellow an hour and green 2 hours for the medical review. And this is on top of the time that the midwife 2 has to complete their assessment. I think the more we don't meet these timings, the more there's going to be, hopefully, a need for implementing more ACPs and looking at the staffing in maternity triage. So some of the difficulties have been actually having the time to escalate when patients have breached. So we and our board management. So I've been to units where they have electronic boards which will look at the times that patients have been and if they've breached. We at the moment have still got a whiteboard, and it's not very clear what timings are what. So it's not very clear who's waiting to be seen by what, and how to prioritize those patients when you walk in, who is the highest priority to be seen. So I think that, and especially when we have unfamiliar staffing, so midwives in triage who aren't core triage or core antenatal, then it makes a real big difference. But hopefully, as we settle into this review time, I think it should make a big difference. And hopefully, as we get a bit better at escalating when these times aren't the times aren't being met, it should support the need for further ACPs. So my day as a trainee ACP, so this is what I was doing. So I was doing 8 till 8. So in the morning we'd have a whole unit S-bar with the MDT, and then do our ward rounds, delivery suite and the antenatal ward round, and look at the incoming inductions and prescriptions. So the ward rounds were more for a teaching, learning perspective, but they actually gave a really, really good overview of the unit for that day. But having decided, kind of coming to a plan with what we're going to do with my role next, I'm not sure that's going to stay in, but for a training year, that's been really, really helpful. And then after all of that's finished, which is normally kind of lunchtime, in the afternoon, I would be kind of based in triage. I carry a bleep, so for reviews for patients outside of triage, so if anyone on delivery suite needed anything, or the day assessment unit, then I could always be bleeped. And what I was doing is every single patient I saw, I would, to begin with, between each patient, while they were still in the unit, I would go and find a registrar or consultant and discuss my care plan. But as that went on, I was making the plans and then catching up every so often, and changing them if required, but not often. And as I said before, escalating any review that I was unsure of. So any kind of medical review or any more complicated patient that I just wanted a bit of extra input, I would escalate that, and then teaching as and when. So that was my day as a trainee. For my dissertation, I just wanted to share, for my dissertation, I looked at midwives' perceptions of the introduction of ACPs into the inpatient maternity services, which was really interesting, actually. So I did a qualitative study with interviews with 6 inpatient midwives. And my literature review, looking at it before, and I think this speaks to how little awareness is there, is that I couldn't identify any published study evaluating the use of ACPs in maternity in the UK. There were ACPs and AMPs, which I think is the European equivalent, in Belgium and Ireland, but nothing published in the UK. And their barriers, very similar to, I think, what everyone is aware of, were insufficient, the budget and staffing constraints, difficulty measuring the value of an ACP, and I think that that's something that we can do easily. It's just getting some standards that we work against, and I think looking at waiting times, patient experience, things like that are a really good way to do that. Lack of awareness and lack of regulation, and I know that some enablers were having good organisational support from the start, and how it's kind of a role that's been developed organically from a gap in the unit. So it's not something that this is the job, this is it, this is the gap, what can we do? So our findings were that, as I've mentioned many times, a lack of understanding of the skills and remit of the ACP. So although people thought it was really good, they had real limited knowledge of the ACP, limited knowledge of the training and understanding of the training that they'd undertaken, and a trust in the ability as well, because I think you want to know that you can trust the person you're handing over care of a patient to. The expectations of the ACP were, where should they sit? Are they registrar level? Are they SHO level? Very quickly, and that it's very much a clinical role, whereas we're not looking at the 4 pillars, and also the midwife's appraisal of the ACP. So how it greatly improves the service provided to the patient and reduces waiting times, a more holistic review, but then patients are aware it's some midwives were concerned it was a bit too doctory. So I've put in a few recommendations on there about doing a wider study looking at other members of the MDT. And very, very quickly, finally, looking at what's next for us. So for myself, I've just, as I said, just started. I'm waiting a job plan and description. And one of the big things, which I'll just touch on very quickly, is that the head of midwifery at the moment we haven't got funding for me to be in addition to the midwife numbers. So the plan is for me to go in to replace the band 7 in triage, so work as midwife 1 and an ACP, which I very strongly believe won't work. But that's where we're at, and yeah, those are those. So I believe these slides are going to be sent out, so we can, if there's anything else. But thank you very much for listening. I don't know if we've got time for questions now or at the end.
Thank you, Ashlea. Congratulations on your new job from Monday.
Thank you.
There's a couple of comments that I'll just read quickly for you. So Sophie Parker says, wow, Ashlea, what a journey you've been on. Congratulations on the achievement. Amazing work, Ashlea. This will contribute so well to the development of and to the conversation around ACP and midwifery. And I echo that. We're next going to go on to case studies in triage with Sam. Would you be able to join Sam for questions at the end of the case studies she's going to present?
Yes, of course. Yeah.
Perfect. Brilliant. So we'll do that. And then if any other questions come through specifically for you during that time, then I can ask you those then once we've gone through that.
Lovely. Thank you.
Brilliant. Thank you, Ashlea.